I will be talking about industrial innovations in vaccines and in the COVID-19 pandemic and post-pandemic periods. But really what occurred to me as I was actually writing the slides is telling the story really requires talking about what came before COVID-19, because what happened in the COVID-19 vaccine response really built on what came before. And an obligatory disclosure, I really am a complete corporate tool. So I'm an officer and shareholder of GSK, and I'll be talking about what came before, which involves talking about things from Pfizer and Novartis, but that's all publicly available information. And so I'll start off by just mentioning that something that seems downright quaint right now, and that was the 2009 pandemic, which of course it did spread globally very, very rapidly and very thoroughly, but of course had a far lesser death rate and impact than the COVID-19 pandemic. It was really during that pandemic and the response to it that we learned many lessons and went on to do a lot of activity, obviously much of it in government and in academics, but also in industry that really prepared us for what was to come in 2019. And there's a lot of talk about how the response to COVID-19 was the fastest vaccine development in history. And in a sense, that's true if you're talking about novel vaccines, but actually the response to the 2009 pandemic was much faster because it was a flu outbreak. And therefore, we knew how to make the vaccine. It's not quite the same thing to make a pandemic vaccine as a seasonal vaccine, in particular, because human immunity is different. And you need to do a trial to figure out what is the right dose and regimen. Nevertheless, it was about 4 months or so from getting the virus to the time that vaccines started to be tested and then rolled out, as compared to 8 months, basically, for this recent pandemic. So it was actually twice as fast. But what we realized at the time was that it was too slow. And something very funny happened to this graph. The pandemic did not abruptly stop when the vaccine came out like it looks there. It didn't fall off a cliff. That's a little PowerPoint thing. But if it were there, what you would see was something very deceptive. And it appears that this outbreak peaked right about when the vaccine came out and started to come down. And it looks as if, wonderful. All right, that's okay. You can imagine the rest. Imagine a nice bell-shaped curve there of the pandemic. And in fact, really too little vaccine came out at the peak of the pandemic to have had any real impact. The vaccine had an impact, but it wasn't in 2009 at the time of the pandemic. It was in 2010 when the pandemic strain became a seasonal strain. Now, during that time, we first started to really think differently about how we might respond to pandemics. In fact, I remember the phone call. At the time, I was at Novartis and leading influenza vaccine R&D. And I got a call from my boss at the time, Rino Rapoli, who said, we've had this big funding grant from BARDA to build a cell culture pandemic response facility in Holly Springs, North Carolina. And there's that outbreak in Mexico of H1N1. Well, there are now cases in San Diego. And at the time, the head of BARDA, Robin Robinson, said to me, do something about it. And so he said to me, okay, basically do something about it. By the way, there is a sequence somewhere on the web for this virus. This was on a Friday. And so next Tuesday, I'm meeting with Robin again, and we need to say what we're going to do. Now, at the time, the way you responded to any flu outbreak was the same. You went to your mailbox and you waited. You would often wait a couple of months. And eventually the WHO would send you a virus, a seed virus, or one of the collaborating centers, and you would then go and make the vaccine from that seed influenza virus, a virus adapted for growth in either eggs or cell culture. Well, this time there was a sequence on the web, and what were we going to do with that? And at the time, we had a facility in Siena where they did a lot of basic science, and there was a graduate student there, I believe, who used influenza reverse genetics to make flu viruses for mouse immunology studies. And they thought, well, heck, why not just use that sequence? Why not take the sequence off the web, synthesize the gene, and make the seed virus? Well, we tried that. It didn't work. We couldn't synthesize rapidly and accurately enough, but the CDC did send us RNA before they could send us virus. And we actually made a virus, a seed virus, but then we had to remake it in BSL, we had to make it in GMP, good manufacturing process, something suitable for making a product for humans. And so we actually went to Marburg, Germany, where we had a facility right across the valley from the University of Marburg, which had a BSL-4 lab. We didn't need BSL-4 for containment. We needed it for control for manufacturing purposes. And we actually made a seed virus from the RNA that was sent to us by CDC. And within a couple of days of that, we received the virus from the WHO. Now, the WHO today, it has something like 130 collaborating centers around the world, as well as, or rather, individual national influenza centers and several collaborating centers. Then it wasn't quite as much, but it was still extensive. And it occurred to us if we could really take a research process, rescuing of flu viruses, and make it GMP in the same amount of time it took the current system to use its huge network of worldwide labs and send us a virus, well, what if we'd actually prepared for this? And so we contacted BARDA, which is the Biomedical Advanced Research and Development Authority, and we asked for some money and a partnership to develop a process to synthesize flu viruses very rapidly, thinking that this new way of making vaccines might be a much better way to respond to outbreaks. Well, in fact, we did that. And in 2013, about 4 years later, we had a chance to actually try out the system. And that was, and this is inaccurate up there. It says, well, no, this one's fine. There was an outbreak of H7N9 influenza in Shanghai. And we actually put the system into practice to try to make a vaccine against that virus. And I'll show more about the details of what happened in the first days later, but the bottom line is, again, there was an initial contact that, there's something out there. There's a sequence on the web, but this time we had a system. With BARDA funding, we partnered with Craig Vender's lab, and we came up with a way to sequence, or rather to synthesize both rapidly and accurately using enzymatic error correction. And we came up with a system. And I'll come back to the first part of that, but you see, this one's about 3 months. And of course, it never became a pandemic. So this, we made the virus, made vaccine, brought to clinical trials, and then it went into the pre-pandemic stockpile instead of into lots of people's arms. At the time, we were also working, and we were one of a couple of groups working on a new way of making vaccines. And that was rather than, for example, making a subunit, or a live attenuated or a killed vaccine, we're starting to make them from RNA. And it came up in a kind of a roundabout way. We have been working on alphavirus replicon technology. Now, alphaviruses are very nasty viruses, but they elicit a terrific immune response. And we had this thought, we weren't the only ones to have it, that if you could express your target of interest from a defective alphavirus, or in this case, a virus-like particle, and deliver that RNA would then replicate in the cell. You get a burst of protein expression. You'd call in the innate immune system, and you would get a terrific immune response. And that actually works. But there was a problem. And I started off by saying alphaviruses are nasty. They also recombine a lot. And the problem is we were delivering that material by having the replicon, the part we wanted, the RNA that replicates and expresses the antigen of interest, and delivering it with the viral glycoproteins, the entry apparatus of that virus, but encoding them on different genetic elements. So in theory, you wouldn't get a virus back. The problem is that's the theory. When you get up to industrial scale and growing things in giant tanks, rare events happen. And we became, without going into unnecessary detail, we became convinced that this was not a good idea to do at large scale. And I was working at that time with Christian Mandel. And he said, well, the part we want of this thing is the RNA that replicates inside the cell. But if you don't deliver it with a viral entry apparatus, which through co-packaging, complementation, recombination could regenerate a virulent virus, could we deliver it a different way? And the thought was, well, why not deliver it with lipids and just take the RNA that we wanted and deliver it in a safer way? So we started working at that time also on lipid-based delivery systems. Again, we're not the only people working on this. This all happened in the context of a lot of work going on in other places as well. So that was another sort of key technology that would come into play later. So the first was sort of synthetic biology, using the ability to synthesize genes so that you're not dependent on a virus being shipped to you from somewhere where the outbreak was. Another was the notion that you could make a genetic-based vaccine where the genetic material in the form of RNA was the actual vaccine, and that you could deliver it in a way that is safer than using a viral entry apparatus, which could potentially, through a series of events that are individually unlikely, but when you think of the number of events in a giant bioreactor, rare things happen, to do this safely as well. So I showed the timeline before how we responded by we made the influenza virus. H7N9, in fact, the CDC didn't even have it. The first H7N9 pre-pandemic virus in the US was synthesized in our laboratories. So you could literally get the sequence off the web and make the virus, except we didn't make the fully virulent virus. You made it on a attenuated backbone for safety and for manufacturing purposes. But at the same time, the sequence was released on day one. Our colleagues in California, Craig Venner's group, had the gene synthesized by day 3. It was shipped across to our laboratories in Cambridge. That took overnight. And by day 6, I believe, is that what I said? Yeah. So by day 6, here we're talking not a virus, but a replicon, because at the same time we rescued the virus to make the vaccine that ultimately went into the pre-pandemic stockpile, we also made an RNA vaccine. Now, to make the vaccine that actually goes in the stockpile, it takes a lot more. You have to then scale up. You have to purify it. Lots of work has to be done. But the RNA you can make right away. And actually, the RNA had a role to play. And that is we needed antibodies against the H7HA. And we simply immunized mice with that RNA replicon. We got antibodies. And that was used to test the actual vaccine that went into the stockpile. So it was a real pilot run showing that this kind of thing could work. Now, I'm going to jump forward a lot. Another company, I will say that, at Novartis, we had wonderful science, lots of great scientific. We didn't have great development for vaccines at that time, and so it collapsed. We just simply didn't meet the goals, and we were broken up into pieces and sold off to various places. One big piece went to GSK, where I work now. So I'm actually rejoining some of my old colleagues. But at that time, I departed, and I went to Pfizer. And at that time, one of the goals was to bring a viral pipeline, to bring RNA technology. And part of doing that was forming a partnership with a company in Germany named BioNTech. It wasn't my idea. I thought, why do I want to work with BioNTech? They're an oncology company. But I had a very, very smart colleague named Julia Lee, who was a virologist, who decided she would get a financial analyst certification in her spare time. She did, and she became a great business development person. And she said, Phil, BioNTech has, first, a wonderful CEO, Ugur Sahin. He's a real scientist, does innovative work. They are an oncology company, but they want to get into vaccines. They need infectious disease expertise, and they also need the ability to scale and industrialize. We have that. They have what we want, some of this early RNA technology, which had not been developed previously at Pfizer. We have what they want, infectious disease and industrial capacity. So we got together, and we didn't get together to work on COVID. Nobody knew about SARS-CoV-2 at the time. We got together to work on flu, and we started working together. And then 2019 happened, and SARS coronavirus 2 started spreading. And Ugur called up and said, Phil, I know we're working on flu, but shouldn't we be working on COVID-19? And I said, yes, but. Yes, we should work on it. And certainly getting tens of people together in a lab to start making some seed DNA for RNA makes perfect sense. But remember, SARS-CoV-1, we contained with just conventional public health measures. MERS, yes, we still have some zoonotic spread from camels, but we contain that also with conventional public health measures. Let's not bet the farm on this right now. But then, in February, I thought this was an MMWR, but when I looked to do this document, it wasn't. It was actually just a much more low-key announcement. This one was from the from California Department of Public Health. And look at that line at the bottom. It's small print. I apologize. It says, it talked about a case. It says, the individual is a resident of Solano County and is receiving medical care, blah, blah, blah. The individual had no known exposure to the virus through travel or close contact with a known infected individual. And this was an alarm bell. This meant this virus was spreading asymptomatically. And it was in the United States, spreading, as you recall, the diagnostic testing early on wasn't what we would have wanted it to be. And then we realized, wait a minute, we do need a vaccine for this one. This is, if it spreads asymptomatically, the chances of containing this are very small. And then now I'm going to say some things that sound like I'm saying things I shouldn't say, but it's fine because it's been published in books a lot and whatnot. We had a meeting at Pfizer with Albert Bourla, the CEO. And now the Pfizer vaccine R&D is located in Rockland County in New York, just north of Manhattan. Also, because of communities there that really don't accept vaccines much, a hotbed for infectious disease. And it was a disaster. I used to go walking in the early evening up to a cemetery, which is on this hill, beautiful view of the Hudson River. Full of wildlife, beautiful place. And it's right above the hospital. And around that time, you would walk through the hospital and there were the refrigerator trucks for all the bodies. And you went up in the cemetery, and it was full of fresh graves. Usually you see one or two. Now it was full of them. And so there was this real sense of crisis. First hit Milan, and then it hit the New York metropolitan area as the real focus. So this felt like an existential crisis. And basically Albert said, we need to do something. And he said something to me that has never been said before and will probably never be said again. You have an unlimited budget. He said, well, your starting budget is $3 billion, but if you need more, just let me know. But he said some other things. I said, wait a minute. The RNA technology, it needs to be frozen. The vaccine needs to be frozen at minus 70 degrees. And I remember a friend response said, that is not the attitude I want. I didn't ask you why you can't do it. I asked you how you're going to do it. I told you you had unlimited resources. So don't give me this. Just tell me how you're going to do it. And so with our colleagues at BioNTech, we launched something, and this is probably beside the scale. Just note, the previous one, the big red circles were 5,000. This one was 30,000. And of course, the lethality was higher. And this just goes to the point that this was a true crisis. And so, as did Moderna, Pfizer, and I should certainly mention our BioNTech collaborators, took this new technology, and we decided we were going to go full steam and make an RNA vaccine. Now, here's where I have to talk about some other streams of technology, some of them academic, some of them governmental, some of them industrial, that came together to make this happen. Because, of course, this didn't happen just at the time. One key stream of technology was nucleoside modification. Now, the self-amplifying RNA technology that we had developed at Novartis, I've never seen anything that works so well in the lab. It's extraordinary. Tiny quantities work, but it's a great big RNA. It's like more than 10,000 bases, and both the 5' end, the start of it, and the 3' end have to be right because it has to replicate, so you need both ends for the replication. That means that while you can get it to work really well in the lab, it's a big challenge to make work, to grow it to scale, to industrialize it, to make it consistently batch to batch and have it be stable on storage, so it will still work when it actually gets to the vaccine recipient's arm. It's like a racehorse. It can go like crazy, but it's skittish. This is like a plow horse, and this is the work, really the credit goes to the first author here, Katie Carrico, who has, now she has a Nobel Prize, but back then, she worked in obscurity. And really persisted in quite an amazing way. And she made a fundamental biological observation and started to adapt it for RNA vaccines, and that is that we don't want to have an immune reaction to our own RNA in the cytoplasm, an innate immune reaction, but we do want to respond to, for example, intracellular bacteria, or in some cases, viruses. And so we modify our RNA. And one of the big problems with RNA vaccines, particularly before this technology, was that they were just too reactogenic. And so what she found is that by making modifications to the RNA like those we make to keep the RNA, our own RNA, from eliciting severe immune responses, you could really quiet the immune response that you don't want, the innate immune response. You want a little bit of it to call in adaptive immunity, but you don't want so much that it just hurts too much and makes you feel too terrible to have a vaccine. And so this is pseudouridine, where you can see the N and C have swapped positions. This is not what's in the vaccine, actually. It's 1-methyl pseudouridine, which is the same as this, except the blue N has a methyl group off of it. So it's of that technology, but that turned out to be critical, and this turned out to be a workhorse. Once you quell the innate immunity, it's not nearly so skittish, and it became a much more reliable technology. Second, I would love to talk at great length about this, but Jason is in fact the expert here, and he, in working with Barney, did extraordinary work way back, starting with MERS, and then showing that the same modification that locked in the pre-fusion form, and maybe we don't have time. I expect that Jason went into all that, so I can skip that and stay within my 30 minutes. Locked in, and they showed that not only does it work for MERS, it works for SARS-CoV-1, it works for seasonal coronaviruses. So at the time SARS-CoV-2 came out, everybody knew exactly what they wanted. Maybe there were a couple of variations whether you wanted just one domain, but if you wanted the whole protein, everyone knew this was the antigen to make. So another stream of technologies, there's synthetic biology, there's nucleoside modification, there's RNA vaccines, there's structural biology and structural vaccinology, all really came together. There are other forms of innovation as well that occurred at that time. And here's where really two quite different companies came together. Pfizer has a clinical development machine. They refined it on an 80,000 person trial for when they made the pneumococcal vaccine Prevnar. BioNTech was an innovative biotech, and they did oncology trials. And in oncology trials, they often do what they call umbrella trials because there's so many variables to test with an oncology regimen that rather than what you usually would do for a vaccine trial, which is to have a couple of endpoints, a couple of groups, they would have, oncologists will often have many groups, and they have an adaptive trial, and they go through and they select between the groups. So there's innovation trial design as well, in that we actually had over 70 groups that we could have gone to for that trial because we needed to decide on the construct, the dose, the regimen in different age groups. And so we went through this, and of course we didn't execute all 70 groups, but through this incredibly efficient serology machine, you could literally get blood drawn on Monday, have the serology result on Friday, and decide what you're going to do the next week. What group would you actually execute the next week in the trial? So this extraordinarily efficient phase 1 trial design. And not only that, that phase 1 trial was part of, I think, the world's first and maybe the only phase 1, 2, 3 clinical trial, a continuous clinical trial where you went from the start to the finish without a pause. So there was that sort of innovation as well. And what was, of course, a tremendous relief is that when we got our first clinical trial results back, we found 95% efficacy. Look at that graph on the insert. That is efficacy. So actually, who's getting sick, who's not getting sick. And the attack rate was so intense that you could follow literally day by day the impact of the vaccine. What does it look like? 1 day out from immunization, 2 days, 3 days. And you could see right there that at about, 9, 10 days, I'm a little bit of an angle here, you started to see vaccine efficacy, and basically the curve went flat. Well, and this wasn't just a finding that said that the technology worked. This told us something very important. I mean, think of some of the new disease outbreaks there have been, whether it's HIV, for example, where you find you just have a vaccine you can't immunize. A virus is very hard to immunize against. This said that this may be a nasty virus in a lot of ways, but it's very susceptible to vaccine-based immunity. So this was a wonderful finding and a release, but this isn't the stop of the innovation. Then actually it went sort of beyond the scientists. It was time for the engineers to innovate, because now you have this vaccine that you know works, that you know has a good safety profile, and you need to get it to many millions and ultimately billions of doses, and you got to distribute them, but it has to be frozen at minus 70 degrees. And so there are huge industrial issues here. For example, you're used to making vaccines. Maybe you get a whole lot of eggs or a whole lot of cell culture. Here you made an RNA vaccine. You need to get not just nucleosides. You need to get modified nucleosides. You need to get the cap that goes on the 5' end. You need to get novel lipids that had not been industrialized before. All this had to be done incredibly fast. Then you had to distribute it to distribution centers that would hold it at minus 70 degrees so it could go, yes, an academic research center, medical center, you could put it at minus 70. But at your doctor's office, at CVS, you can't freeze it at minus 70. So you had to have a network of distribution by airplanes, by local distribution centers, a whole network, so you could actually execute on this. And this is the work that made the industrial engineers, as well as distribution experts, all had to do in very rapid fashion to be able to get this vaccine out. And they did it. In parallel, there were other efforts that went on, also all built on what had come before. There was the engineered monoclonal antibodies to be used for treatment. There was the antivirals, and here again, it very much built on what came before. This was actually a SARS-CoV-1 antiviral work for a protease inhibitor that started with the first SARS outbreak. And the goal was to first find out, does it work for SARS-CoV-2? It did. Then could you make it orally available, et cetera. So the reason it could go fast was because of the preparation that had been done ahead of time, sometimes inadvertently, but it had been done. I mentioned, of course, we came up with we had to adapt for new strain changes. That became apparent quite soon. And that synthetic virology technology, the notion that you could go from a sequence to a virus very quickly, was critical. Because early on we had discussions with some governments that said they had connections all over the world and they could collect all the viruses and send them to us. Well, that didn't work so well. It was the technology that allowed, actually, University of Texas to make a new SARS coronavirus every time a new sequence showed up that was significantly different from one before, so you could test the sera from your vaccine trial against it. Admittedly, it's not all neutralizing antibody. Neutralizing antibody is a big piece of it, so you could very rapidly determine, is the vaccine likely to cover this or not? And that was, again, using the synthetic virology technology that had been developed for a number of reasons, but in part to respond to previous outbreaks. So, does this leave us sort of better off for the next pandemic? Well, one thing that is so encouraging is that the notion that you're going to make technologies and build industrial organizations, factories, blah, 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 for something that occurs a couple of times a century or a few times a century at unpredictable intervals, that is a non-viable business model. So for these things to really work, they have to be applied for seasonal, regular, routine use. And that is what we're seeing. Now, the engineering that went into SARS-CoV-2 actually had happened earlier for RSV, and I assume, Jason, you talked about that. Okay, Barney. So I'm sure Barney will cover it very well. And we are now seeing a couple of vaccines that are now in launch that are using this structural engineering to make better RSV vaccines, and those are not pandemic vaccines. These are vaccines for routine clinical use. The RNA technology. We're seeing a race right now to use that technology for routine seasonal influenza immunization, perhaps combined with COVID-19 immunization as well. Again, the technologies that really were industrialized for the purpose of the pandemic are now going into, are on the cusp of going into routine clinical use for non-pandemic purposes. And this is important because I'll wind up with a sort of a sobering thought, and pandemics come. These are maps of H5N1 avian influenza, and the map on the left side talks about what was seen in the Americas from 2007 to 2021. And the one on the right is 2021 to 2023. And what you'll notice is there's a whole lot more on the right. And in fact, there is a new clade of H5N1, and H5N1 is extremely virulent. I forget what the exact mortality rate is for SARS-CoV-2, but I believe it is under 1%, at least in the circumstances that exist in much of the world, the mortality rate for this thing is 60%. And it has fortunately not spread widely in humans, but this new clade of H5N1 has spread like wildfire through the avian populations, not only of North America and the flyways, it spread all the way down the Pacific coast of South America with mammals, particularly those that eat the birds, getting infected, and occasional spillover into humans. So we can't think that this is over. So the fact that we have gone through the industrialization of these technologies, that they're now being used for routine immunization, starting with RSV and then progressing perhaps to other routine vaccines as well, is a very good sign. And there's definitely a tendency that it's a giant emergency when the pandemic is happening, and then after the pandemic, it tends to get forgotten, but not entirely forgotten, which is good. There's now a White House Office of Pandemic Preparedness and Response, which is a very good thing to see. Many of our plans for preparedness kind of fell apart in the years just before the pandemic. But it's important to remember that the next one will come, so that making sure we continue to learn the lessons, that we have the organization, and that we're ready to move very fast again is extremely important. So thanks.